our next session, which is lower urinary tract infection in type 2 diabetes mellitus. And to speak on this particular session, I would like to invite Dr. Rajesh Loonia, sir, who is a neurosurgeon. And to chair this particular session, I would like to invite Dr. Buddhadev Mukherjee. He is a very senior physician from Howrah and also the patron of Howrah Diabetes Study Society. Sir, I invite you on stage. Sir, I invite Dr. Rajesh Loonia to kindly speak on this particular session.
Urinary tract obstruction. He is one of the renowned urologists practicing both in Calcutta and also he is one of the most important urologists practicing in Howrah and also in Calcutta. I request Dr. Rajesh Loonia to deliver his session. Thank you. Please.
Okay. Thank you, sir, for kind introduction. At the outset, I wholeheartedly thank Howrah Diabetic Society for giving me this opportunity. I can see that today is the cricket match and at the end of the session you all are tired, so I will keep it short and simple. My topic is diabetes and LUTS. Diabetes and benign prostatic hyperplasia both can cause LUTS, and often they are interrelated. The LUTS caused by LUTS are often due to both the reasons. The patients have LUTS because of the benign prostatic hyperplasia as well as diabetes. In fact, many a times we do diagnose diabetes. Patient come to us with the problem of the urinary frequency, urgency, recurrent UTIs, and on the evaluation we are first to diagnose the patient is suffering from the diabetes. And control of diabetes in these patients give the excellent result. They do not require any other therapy, just the control of diabetes suffice. So in the elderly male, aging male population, it's very important when the patient comes to a clinician for the evaluation that diabetes should be ruled out at any patient who comes to you with the LUTS. I am Dr. Rajesh Loonia. I am working at the Narayana Super Speciality Hospital, Howrah. BPH is unregulated proliferation of connective tissue, smooth muscle and glandular epithelium of the prostate leading to prostate gland enlargement. The enlarged prostate causes the mechanical compression of urethra leading to bladder outlet obstruction. The clinical manifestation of BPH are myriad. There are multiple manifestations and some of these manifestations are interconnected. Most common manifestation is asymptomatic. Most of the patients are asymptomatic. More than half of the patients with the BPH prostatic enlargement have no symptoms. Then comes the LUTS or lower urinary tract symptoms. Thank you.
Only you could have.
Thank you so much. Then the most common clinical manifestation, patients who are symptomatic, most common symptoms are lower urinary tract symptoms, mainly frequency, urgency, nocturia, incomplete voiding, intermittency, hesitate to void. These symptoms can be divided into two categories. One is the bothersome symptoms, another is non-bothersome symptoms. Patient will come to you obviously for the bothersome symptoms. Most of the patient will ignore the mild symptoms. BPH will also need to incomplete bladder emptying, which will, particularly in the diabetic patient, will lead to recurrent UTIs and urosepsis. Untreated diabetes and untreated BPH is a bad combination. Patient can land up in the urosepsis very easily. Incomplete bladder emptying will also lead to acute and chronic urinary retention, and in extreme cases, chronic neglected cases, chronic renal insufficiency. It's not uncommon to see the patient presenting to us with the raised creatinine and bilateral hydroerythronephrosis and a palpable bladder. Etiology of BPH is not very clear. There are many hypotheses. One of the most appealing or accepted hypothesis of BPH is related to metabolic syndrome. Metabolic syndrome, diabetes is also part of metabolic syndrome, and BPH is also a manifestation of metabolic syndrome. Insulin resistance, hypertension, obesity, dyslipidemia lead to hormonal changes in hormonal milieu and inflammation, which aggravate the benign BPH. Prevalence of BPH. BPH is a disease of aging male. As we age, it's 8% in 4th decade and in 80% in the 9th decade of life. Older age is a risk factor for BPH onset and clinical progression. Younger patients are typically asymptomatic as the patient becomes symptomatic as the patient ages. And obesity is also a risk factor for BPH. There is 3.5-fold increased risk of prostatic enlargement in obese patient compared to non-obese. So obesity is also a risk factor for diabetes. So let me elaborate further. Metabolic syndrome. This is how metabolic syndrome and diabetes is involved in the pathogenesis of LUTS. Insulin resistance lead to sympathetic nervous system activation. Hormonal changes will cause increased estradiol and lower testosterone. Pelvic atherosclerosis will cause bladder and prostatic ischemia and inflammation. Induced cytokine release will all lead to LUTS and the pathological reaction of hyperplasia. Prevalence, epidemiology of, if you look at the epidemiology of metabolic syndrome, prevalence of metabolic syndrome in mild LUTS increases up to the 40%, but no further increase in the moderate to severe LUTS group. Risk of having severe metabolic syndrome in patient with the BPH is increased by 37%. Metabolic syndrome, there is a study which looked at the metabolic syndrome and prostatic growth in patient with the BPH. So annual prostatic growth and annual transitional growth rate were significantly higher in the patient with the metabolic syndrome. BPH patient with the metabolic syndrome have higher prostatic growth and larger prostatic volume, and those without the metabolic syndrome. And these patients are typically more symptomatic. So now coming to the diabetes. Association with the diabetes and BPH is very strong. Patient with the history of diabetes had twice the risk of moderate to severe LUTS. Their LUTS are typically more severe. In diabetic patient, LUTS are more severe. Patient with the diabetes and BPH has impaired detrusor function due to chronic neurological involvement, and lower maximum flow rates, and increased post-war residual urine, and increased severity of LUTS, and UTIs and urosepsis. Diabetes, BPH can be, the pre-diabetes and BPH are interlinked. This is the hypothetical association between the BPH and diabetes. These all are postulation, the hypothesis. None of them are actually proven, but this is at this moment of time, this appears to be the most appealing hypothesis. the sympathetic overactivity, insulin-like growth factor activity, alteration in the sex steroid metabolism, and inflammation in pre-diabetes will lead to BPH and LUTS. Now, most of the diabetic patients also have heart disease and hypertension as a comorbidities. So these patients, these two conditions will also affect the LUTS. A study on the 158 Swedish men showed that diabetes with the treated hypertension has larger prostate volume and higher growth rates. Similarly, occurrence of coronary artery disease among the BPH patient is higher than the patient without BPH. Occurrence of the CAD in the subject with the BPH was significantly higher than the subject without BPH. Similarly, the occurrence of BPH was higher among the subject with CAD as compared to patient without CAD. Another manifestation of diabetes, another is erectile dysfunction. Benign prostatic hyperplasia is also related to erectile dysfunction. The interrelation exact mechanism is not clear. There are 4 theories which are postulated in the literature are: one is the increase in Rho kinase enzyme activation resulting in the decreased smooth muscle relaxation, and another are autonomic androgen and chronic inflammation, impaired nitrous oxide in the endothelium of the prostate, and atherosclerosis of the blood vessels supplying in the penile region. They all lead to erectile dysfunction. So 70% of BPH patients also suffer from erectile dysfunction. And now coming to the management of this condition. Alpha blocker patient, the treatment is usually not different with the patient with the diabetes. BPH with diabetes, the treatment remains the same, but patient require the tight control of blood sugar. Unless we control the blood sugar, the alpha blocker are typically ineffective. Once you will control the blood sugar, symptom will reduce remarkably, and then if you add the alpha blocker, patient will have further clinical gain. All the alpha blocker, tamsulosin, alfuzosin, silodosin, doxazosin, terazosin can be given. In the patient with the diabetes, alpha blocker have higher improved rate of IPSS and Bodder score compared to non-diabetic patients. So percentage of improvement in IPSS score is non-diabetes is 23% and diabetes is 46%. Improvement in Bodder score is similarly better in diabetic, same for the Qmax. Tamsulosin as well as other alpha blocker achieve the same result, but the efficacy of tamsulosin in BPH patient with metabolic syndrome and diabetes is quite effective in all the studies. I will skip this slide. So in the conclusion, I will say that LUTS may be presenting feature of diabetes. Many a time patient will come to with the LUTS only. So newly all the patient coming to a clinician with the low unit symptom, diabetes should be ruled out. Second, the symptoms are more severe in diabetic patients and they will require treatment of both diabetes as well as LUTS. Once the treatment is started, the efficacy of treatment is also more in diabetics. This is in a nutshell.
Thank you very much for your patience listening. And if I open the floor for any question and answers.
Sir, which, pardon, sir? Yes, yes. Yes, yes. So it can be continued for the decades. Dutasteride, the effect of dutasteride in elderly is
Sir,
in the patients.
nowadays few studies have come. They are suggesting 3 years.
Sir, there are multiple school of opinion. There are few studies now is suggesting that the reduced duration of dutasteride, but it will come at the cost of poor symptom control.
Atherosclerotic, cardiac,
and the progression of
and bone
BPH,
disorders.
which is quite significant, retention of urine, need for the surgery or the urosepsis and UTIs. So, dutasteride have the side effects. Okay, I agree, but the beneficial part of dutasteride will overweigh the side effect. Can be continued for indefinitely, maybe for the decades, if needed. Dutasteride typically shrinkage in the long term, if it's 3-4 years, around 60% of prostatic mass in the patients. 62, we can achieve 60 to 70% of shrinkage of prostate in a long term basis. But this is dose dependent and as well as duration dependent. Once you stop the dutasteride, prostate will regrow quite quickly. So it is recommended, many say there is no clear cut consensus on this topic, but we can, as a general rule, we can continue till the patient is symptomatic. Dutasteride in the last prostate can be continued indefinitely. There one study we saw the long-term dutasteride treatment can cause aggressive prostate cancer. But another study showed that dutasteride is protective for the prostate cancer. As of now, there is no consensus. There is either in the for or against.
Thank you, sir.
Thank you.
Thank you very much for this fine session. Next,
thank you. Yes, yes. Hemodynamic study, there are several indications for the, if you suspect the neurogenic symptoms, the involvement of the chronic diabetic patient, autonomic neuropathy, then the UDS is indicated. Patient who have a chronic retention of urine, hemodynamics indicated. Patient who are not responding to therapy despite optimal therapy, they require hemodynamics. All the patient who require surgery ideally should be evaluated by urodynamic study. Yes, is very important. Not all the patient. The patient who have impaired, we use uroflowmetry and urethrogram as a screening test. If the patient have a normal uroflow and normal urethrogram, then probably he will not require urodynamic study. But if the patient has a history of obstructive uropathy, if the obstructive uropathy is the cause for the chronic renal disease, then obviously the patient will need urodynamic evaluation. Particularly children, those who present with the post-urethral valve or meningomyelocele, these patients will definitely require this. Any patient, typically who comes to you with the bilateral hydroeritonephrosis, and they will require urodynamic study. Okay. Thank you.
Thank you, sir.
I would also like to invite Dr. Guru Prasad Bhattacharya to kindly felicitate Dr. Vivek Kumar, Neurosurgeon, who joined us as chairperson today. Thank you, chairpersons. Thank you, speaker sir, for this wonderful session.
So you can combine one with the another. Now I'm coming to the importance of dietary fiber in the weight and blood glucose management. So if you increase the dietary fiber, it can have many benefits. It can provide many benefits through many mechanisms, like during the chewing, it increases the salivation, therefore it helps in weight management. In the stomach and small intestine, it reduces the level of free fatty acid, cholesterol, glucose and insulin through various mechanisms, therefore it improves the blood glucose. In the large intestine, it increases the level of small chain fatty acids like butyrate because of the fermentation of gut microbiota compositions, and also reduced inflammation, that is meta-inflammation. Now, we all know the type of fibers. There are two types of fibers, soluble fiber and insoluble fibers. Soluble fibers are mainly from oat, bran, barley, etc., and insoluble fiber are mainly from whole grains. So there are many benefits like glucose control, weight management, cholesterol control and digestive health. Now I'm coming to the evidences regarding this fiber replacement for fiber supplementations. The recommendation is 10 to 20 gram per day, at least 10 gram per 1000 kilocalorie per day. So 10 to 20 gram per day in individuals with type 2 diabetes mellitus has shown to reduce the body weight and waist circumference. So fiber recommendation is 25 to 40 gram per day, which plays a role in weight and obesity management. So protein is an essential nutrient helping in weight management by increasing satiety, increase in energy expenditure, promoting muscle mass synthesis because of the supply of amino acids. Protein intake of 1 to 1.2 gram per kg per day shown to reduce the body mass index, waist circumference, fat mass, insulin resistant, and improves the muscle mass as well. There are studies as well, Campos et al. They found that more weight loss in people with metabolic syndrome patients when the patients were given 1.34 kg gram per kg of body weight per day of protein. In another meta-analysis, Dr. Dong J et al., they have showed that high protein diet was found to have beneficial effect on weight loss, HbA1c level and blood pressure as well. So protein recommendation is 1 to 1.2 gram per kg per day. Now I am coming to micronutrients. The mind that there was no current recommendation of routine supplementation of the vitamins above the recommended daily allowances, either to prevent the complications of type 2 diabetes mellitus or development of type 2 diabetes mellitus, unless there is any underlying deficiency state. So reducing the diabetic patients, they have sometimes antioxidant deficiencies like A, C and E deficiency. So in those cases you can supplement. Vitamin D has been shown to be associated with development of diabetes, but it has no clear-cut evidence in the improvement of the diabetic status. And absorption of vitamin B12 may be an issue, particularly in patients those who are getting metformin. And hypomagnesemia and chromium also has got some role in the insulin sensitivity, magnesium replacement and chromium replacement. Now I'm coming to the last part of my talk, that is glycemic variability. We all know about that, but how to combat this glycemic variability? There are many ways. One is definitely the changing of the medication. So oral anti-diabetic drug which are responsible for the higher glycemic variability could be replaced by the drugs. Yes, 2 or 3 slides. So that could be replaced by the glycemic drugs which has less glycemic variability. So diet is a very important factor in modifying the glycemic variability. So I have mentioned that low glycemic index food is very important, and food order, this particularly if the patient takes vegetables and proteins in the beginning of the meal, that can also lower down the glycemic variability. Low carbohydrate diet definitely, and high protein and high fiber diet. So there is a role of diabetes specific protein supplementation in diet in diabetic patient as well, particularly in some conditions like when there is obesity associated with diabetes and malnutrition is associated with diabetes. So this is evidence from that protein improves glycemic variability. You can see that in 10 healthy adults, 0, 5, 10 and 20 gram of protein from glycemic index lowering peptides was added to a 50 gram of glucose drink, and the glucose was measured, capillary glucose was measured at 15, 30, 45, 60 and 90 minutes and 120 minutes. You can see that 20 gram of protein significantly reduced this postprandial glucose excursion, which was depicted by the lowest line. So, DSPS has some scientific design as well, mainly regarding the composition of macronutrient and micronutrient. It has high fiber content and high protein content as well. It has been shown that it can accelerate wound healing in patients with diabetic foot ulcer as well. It can improve glycemic control and also variability, and it can reduce the hospital stay, particularly in hospital setting. So, the takeaways is medical nutrition therapy is an integral component and a cornerstone of diabetes management, not only in type 2 diabetes mellitus patients, but also type 1 diabetes mellitus patients. A balanced diet with the help of MNT plays an important role in the management of diabetes and reduces the risk of diabetes complications in the long run. Individuals with diabetes in India, they consume higher than recommended amount of carbohydrate and lower proteins and also to some extent fibers. Apart from type of carbohydrates, many other factors can also influence the glycemic index of the food. Glycemic index is important, but glycemic load is also very important. Upregulating protein and fiber in the diet plays an important role in reducing the glycemic index as well as the glycemic variability, which in turn reduces the risk of complications. So, diabetic specific proteins supplement help to bridge the gap between the insufficient protein intake and the increased requirement in people with diabetes in Indian context. So, with these I would like to stop here.
Thank you, Dr. Vaidya, for explaining in a very nice way about various components of nutrition, reducing carbohydrate, increasing protein, and especially vegetarian protein, because that is not loaded with high fat content, and importance of fiber in reducing glycemic index as well as glycemic variability. I will like to ask one question that is common, that we are consuming a lot of palm oil in India as a cooking media. So, how palm oil stands in diabetic nutrition? Is it damaging, or what is the status of palm oil?
I think the palm oil is unhealthy oil because it contains more of trans fat and saturated fat. So, that is there is a recommendations that regarding the trans fat, as far as we can reduce the amount of trans fat, but the saturated fat, it should be less than or 7% of the total calorie. Yes.
Okay, so one or two questions from the floor.
Take the fruits at the beginning of the meal or the end of the meal? Is there any guidelines?
Actually, in between the meals. Actually, in between the meals. If you take more fruits in the beginning of the meal, that can increase the postprandial glucose because of the high glycemic index of some of the foods. Not all foods, but some of the foods.
And the answer of the question that you have shown.
Watermelon or
Sorry?
non-watermelon?
Oh, okay, okay, fine. So now I think the audience can reconsider their answer. Watermelon actually contains 80 to 90% of the water, but it has very high glycemic index. The glycemic index, we compare the amount of glucose raised over a period of 2 hours with 50 gram of glucose or 50 gram of carbohydrate in white bread, similar amount of carbohydrate in white bread with the same amount of carbohydrate, that is 50 gram of carbohydrate from the another category of carbohydrate food. Am I clear? Are you clear?
Not really.
No,
so area under the curve, suppose after 50 gram of glucose injections, blood glucose rises from the baseline, blood glucose rises 100. And after taking white bread, which contains 50 gram of carbohydrate, blood glucose rises, say for example, 80 milligram. So, area under the curve, this difference or this area under the curve is actually the measure of the glycemic index. It is measured in percentage. So 80% is the glycemic index of the white bread. So am I right? Am I clear? So then you can similarly, you can get the glycemic index of any carbohydrate food. Say for rice, if the polished rice increases the postprandial glucose, polished rice which contains 50 gram of carbohydrate, the amount of rice which contains the 50 gram of carbohydrate, which rises the blood glucose after a period of 2 hours, say for example 70, then its glycemic index is 70. So this glycemic index of watermelon is very high, but the glycemic load is low because 80% or 90% of the constituent is of water. So if you take 100 gram of watermelon, actually you are taking 10 or 20 gram of watermelon. So though the glycemic index is very high, but the glycemic index is low, but the glycemic index is low, glycemic load is low, but the glycemic index is high. On the other hand, the chocolate, which has very high fat content, so that it lowers down its glycemic index. So the chocolate is the answer.
Okay, thank you. And just one point that, as we all know, that protein is good and it should be taken, in greater quantity. But according to NI in Hyderabad, initially the recommendation was 1 gram per kg per day, but they have reduced it to 0.83 grams.
Yes.
So what is the purpose? Why?
The recommendation is, I think the range is 0.8 to 1 gram per kg per day. Not a clear cut 0.8 gram per kg per day. The idea recommendation is 0.8 to 1.
Yes,
the range.
Yes, previously it was 1 and now
if
it
there
has
is
been
no
0.83.
0.8
recently.
I do not know the reason why they have reduced this cutoff. Lemon juice.
Lemon juice number 1, number 2 guava, number 3 cucumber.
Number 3 is the
Cucumber. Sure. Cucumber.
Cucumber contains lots of fibers, and the glycemic index, that's why is very low. Usually we should not consider it as a fruit. We should consider it in salads, actually in vegetables or salads. And regarding the fruit juice, as I have said that fruit juice, it does not contain fibers. Rather, whole fruit contains fibers. So it lowers the glycemic index, but on the other hand, the fruit juice, which is processed, which is made outside, that increases the glycemic index because of the lack of fibers and other constituents. So that causes the sharp rise of postprandial blood glucose. Emni lebu? Achha. I think there should not be any concern, the lemon juice.
Okay, thank.
Don't drink fruits, eat fruits.
Okay, it's a very. Do you have any questions?
These days, lot of studies are coming that showing that consumption of both the fermented and non-fermented dairy products is associated with long-term cardiovascular morbidity and mortality, and also the incidences of cancer. So, lot of controversial studies are now coming. So, what is your take on that?
Fermented products actually contains lots of beneficial bacteria, so that can improve the gut microbiota status. So rather that can reset the gut symbiosis. So that I have shown one of the slides, and I have touched upon those aspects little bit, that how fiber improves the glycemic control and it has got other benefits like inflammations. So that resets the gut dysbiosis. It causes the symbiosis of the gut microbiota, as the fermented products contains lots of favorable bacteria which are important for the prevention of the inflammation, and it increases the small chain fatty acids in the colon, in the large intestine. So that is beneficial actually. That prevents meta-inflammation, that prevents inflammation in the intestinal wall.
Okay, thank you. It's a very nice and interesting session, but because of time constraint, we cannot allow any more questions. So we are concluding the session now. Thank you all.
Thank you, Speaker. Thank you, Chairperson. It's time to felicitate our Speaker. I would like to request our Chairperson to please felicitate him. And now I would like to request Dr. B.P. Pandey to please felicitate one of our Chairperson. And then I would like to request Dr. Sanjay Shah to please felicitate another Chairperson.